Evening, everybody. I'm Dr. Partha Roy. I'm a consultant diabetologist from Bongaigaon, Assam. Today, we'll be talking about the established cardiovascular disease and its complications in diabetes. So, we all know that diabetes and cardiovascular disease are two sides of the coin, and most of the patients with diabetes will end up in severe cardiovascular disease, and the major cause of death in diabetes is due to cardiovascular disease. So, to promote my point, I'll be talking on a case presentation. It is about AB, a 53-year-old corporate executive diagnosed with diabetes 6 months back. When he came for his routine checkup, he complained of weakness. His family history was positive for hypertension and myocardial infarction, a heavy smoker for almost 30 years, but he has quitted this for last 5 years and is trying to live a healthier lifestyle. He has a history of MI 3 years back. On examination, he was 92 kgs of weight, height was 5 feet 8 inches, and BMI was 30.7, which means he was obese, and blood pressure was 140 by 90 millimeter of mercury. So he was borderline hypertensive as well. On laboratory evaluation, his A1C was 8.4, LDLC 137 milligram per deciliter, HDLC 37 milligram per deciliter, which means his HDL is slightly on the lower side and LDL slightly on the higher side. His serum triglyceride was 156 milligram per deciliter. Renal function, EGFR was within normal limit. UACR is 50. Drug history, he was on metformin 1 gram twice daily, telmisartan 40 milligram once daily, atorvastatin 10 milligram once daily, amlodipine 5 milligram once daily, aspirin and clopidogrel 75 and aspirin 75 milligram per day. So from his history, it shows that his A1C is quite on a higher side, and as per as ADS recommendation, we know that if somebody has an A1C which is 1.5% to 2% above target, we should not wait with metformin alone. We should go for a combination therapy, and that this is what we can get from his history. Now, as per as the patient-centric approach of management of diabetes, we know that we should prioritize CV protection, microvascular protection, weight reduction, reach glycemic goals with no hypo events, and convenient dose schedule. Now, for this patient, what should be the ideal drug? As this patient is obese and also has a family history of cardiovascular disease, also he had a history of MI, I think SGLT2 inhibitor is one of the drug of choice. Along with, we can go for GLP-1 analogs. Now, the primary consideration in cardio-renal protection is to optimize glycemic control for CV risk reduction and address any weight issues. By adding SGLT2 DPP4 combination, benefit receipts are cardio-renal protection. Similar regime, cardiovascular disease is a leading cause of morbidity and mortality in adults with type 2 diabetes, with its onset estimated to occur 12 to 15 years earlier in people in type 2 diabetes compared to those without history of type 2 diabetes mellitus. The excess risk of ASCVD in patients with type 2 diabetes has been estimated to be at least twice that those of without diabetes. The Birmingham Offspring study, which was done with 1,945 patients, suggested that 2/3 of the patients with diabetes have subclinical cardiovascular disease. In diabetes mellitus increases the risk of subclinical cardiovascular disease by 4.3 folds. Subclinical cardiovascular disease increases the risk of CV events by 2 folds, and the vascular wall in patients with diabetes is well known to have advanced atherosclerosis. The EMPA heart study, the function and circulation of biomarkers in patients with type 2 diabetes, in patients with type 2 diabetes showed that empagliflozin resulted in early and significant reduction in left ventricular mass regression, and defect by cardiac magnetic resonance imaging, and also suggest reverse cardiac remodeling may be a possible contributor to the cardio-renoprotective effect of SGLT2 inhibitors. In 2015, the era of evolving a dimension of cardiovascular care in type 2 diabetes management began with EMPA-REG outcome study, which demonstrated significant benefit of empagliflozin for cardiovascular mortality by 38% CV events, as well as MACE in type 2 diabetes and CV disease. All types of CV deaths were reduced with empagliflozin. More prominent absolute benefit were observed for heart failure related deaths and certain deaths. The post hoc analysis of EMPA-REG demonstrated consistent CV mortality benefits. Irrespective of the prior CV event, MI or stroke, heart failure burden CKD baseline A1C level controlled of multiple CV risk factors, backgrounds used of metformin. Several mechanisms have been proposed for CV effects of SGLT2 inhibitors, including osmotic diuresis, natriuresis, leading to blood pressure lowering, decrease in arterial stiffness and vascular resistance, decrease in weight, decrease in uric acid, and oxidative stress. It has also been reported that type SGLT2 inhibitors promote reverse cardiac remodeling, improve myocardial energetics and feeling conditions, reduce alveolar stress and mass, and reduce blood pressure and arterial stiffness. The EMPA-Heart CardioLink 6 study demonstrated that empagliflozin could produce early reverse cardiac modeling in type 2 diabetes and stable coronary artery disease. In Carmagina and Carolina trial, zinagliptin has also demonstrated CV and renal safety. Secondary endpoints of zinagliptin versus placebo or active comparator when added to standard care in patients with type 2 diabetes who are at high risk of vascular complications. Empazina is available as a first-in-class treatment in SGLT2 and DPP4 combination group of drug. At week 24, Empazina 25 by 5 milligram showed statistically significant A1C reduction of around 1.08% with standard deviation of baseline 7.99%, and the p-value was 0.001 add-on to metformin. A1C decrement by Empazina 25 by 5 milligram was demonstrated 1.81 A1C reduction at HbA1c baseline of more than 8.5% at 24 weeks. As we know that higher the base, the more the reduction of A1C can be observed. The combination offers a suitable complementary strategy to achieve target A1C without hypoglycemia and weight gain in patients with high baseline A1C level, together with renoprotective benefits in patients. Now, we know that this combination not only helps in reducing the cardiometabolic or cardiovascular risk, but also we know that with SGLT2 given alone, there is more risk of UTI or GTIs. Now, when these two drugs are given together, there is also a very little or reduction of risk for these complications of SGLT2 inhibitor. And so we all suggest that this drug should be one of the first-line drug for the treatment of diabetes in those patients, especially with cardiovascular comorbidities. Thank you very much.